Thank you for coming. I'm really excited to be here talking about medication adherence. Partly because it got me out of work, also got me up here to beautiful Traverse City for a day. Medication adherence has really been looked at closely in the area of specialty pharmacy where I'm from, partially because of the high expense of the medication and the complexity of some of the disease states. But in the last 5 to 10 years, it's been looked at more closely in all areas of healthcare. At the end of the activity, I'm hoping that everybody will be able to discuss various measures of medication adherence, list several positive and negative factors correlating with medication adherence, identify negative outcomes of poor medication adherence or medication non-adherence, and describe tools for predicting and improving a patient's medication adherence. So medication non-adherence has been referred to as America's other drug problem, and with avoidable medical costs nearly $300 billion per year, it's kind of easy to see why. It's been estimated that between 1/3 and 2/3 of hospital admissions can be attributed to medication non-adherence. Preventable adverse drug events, up to 20% of those have been attributed to non-adherence. And then between hospitalizations and adverse drug events, of course there's going to come deaths, so up to 125,000 deaths per year have been attributed to medication non-adherence. So it may be easy to answer this question, why the hype, from all those financial figures in the last slide. But besides the unnecessary medical costs, there's a lot of other reasons why medication adherence has become more prominent in healthcare. For one, there's more data available. A lot more studies and research have been done looking at medication adherence, ways to predict it, and ways to improve it. We'll talk about some of those later on in the presentation. Also, a lot of key stakeholders have become involved, from patient advocacy groups to CMS, and a lot of other groups have gotten involved. And finally, medication adherence benefits everybody involved in healthcare, from the patient to the pharmacist, the drug manufacturer, healthcare plans, etc. So it's understandable why it's been taken a close look at in the last few years. I was curious to kind of take a look at the literature specifically and how that's changed over the last couple decades. I took a fairly common disorder, hypertension, and looked at the research available in PubMed just by a simple search, and also a infection that's really being pushed to find a cure for kind of frantically, HIV. And you can see here that the amount of literature has really grown quite a bit faster in terms of adherence in either of those disease states. I think it's really a vicious cycle. As more literature comes out, more research, people do interventions with patients, and that triggers more questions, so more research is conducted trying to find out more about medication adherence. As we can see here, there is a potential for a large return on investment for improved adherence. In one study, looking at 3 different disease states, it was found that patients with hypertension, if they spent an extra $1, or for every extra $1 they spent adhering to their medications, they would save $4 on their medical benefit. For hyperlipidemia, it was $1 more, $5, and for diabetes, they could save $7 on their medical benefit for every $1 they spent adhering. So for patients, they may spend more on their prescriptions, but they have less overall costs, and more importantly, they have better healthcare outcomes. In addition to patients benefiting, like I said, all other parties in healthcare benefit from improved medication adherence. So we have pharmacists and manufacturers, because they're dispensing medications more frequently on time for patients, more revenue for them. Healthcare plans, they have better outcomes for their patients, so pay-for-performance measures such as their HEDIS scores, those get looked at and are improved by better adherence. Physicians also have some pay-for-performance scores that are affected by medication adherence. And Perhaps maybe the only healthcare entity that wouldn't benefit initially from improved adherence would be the hospitals, because you would see less admissions. But realistically, if the hospitals focus more on accountable care organizations and the patient-centered medical home models, they can still find a way to have sustained revenue. So recognizing the magnitude of this healthcare problem, a lot of key stakeholders have become involved and had something to say. For one, the World Health Organization in 2003 in a report stated that increased medication adherence would have a greater impact than any improvement in any medical treatment. The National Council on Patient Information and Education in 2007 issued a national action plan, including a public education campaign on medication adherence. In response to that, the National Consumer League began research looking for information on medication adherence and ways to improve it, and they received funds from the Agency for Healthcare Research and Quality. And more recently, in 2010, CMS actually added adherence to its plan ratings. So for those star ratings that you see for Medicare Part D plans, adherence is actually one of those measures. So patients that are seeing how the plans are rated, adherence comes into play there. And then very recently, and you may have seen this through some of the e-newsletters from MPA, the Department of Health and Human Services issued a request for information on medication adherence. I spoke with somebody there, and they're actually planning on taking this information that they received and compiling a report to be released in early 2013 on ways to improve medication adherence across the country. These entities right here, patients, government, and just the general public have been exposed to more and more information on medication adherence. We can see here that there's been a lot in the news. You've probably seen it in a lot of your subscriptions about problems with medication adherence and non-compliance. It's even come up in questions about the curriculum in colleges of pharmacy and whether or not adherence is taught enough in the schools of pharmacy. And then with news being so prevalent, it's not really any surprise that entrepreneurs are getting involved, trying to find ways to make an income off of improving adherence. It's really a lucrative opportunity for wholesalers, one of which is AmerisourceBergen, for example. They have a patient adherence program where they have a team of nurses that will call out to patients and talk to them about side effect management. They also have dietitians that will talk with patients about improving their diet. And then we also have anybody with a smartphone or a tablet. You can go into the marketplace right now and find just hundreds of applications with medication reminder functionality, drug information, really targeted at helping the patient maintain adherence. Then we also have business intelligence and consulting groups putting together documents on medication adherence and charging for them. As you can see, they can get quite expensive, $700 for this one from First Word Pharma. Question you might want to ask yourself is how much would you pay for a concise, up-to-date reference on medication adherence? Well, how much did you pay for this CE? A lot less than $700, I hope. We have the cards that Mary included in your folders, multiple choice cards. You may want to grab those out. I have about 4 questions in here. The first one we have is a patient, JC, who was prescribed simvastatin 40 milligrams to be taken once daily. JC takes the prescription to his pharmacy to have it filled and receives a 30-day supply of the medication. And 30 days later, he's out of the medication. Now, assuming that he started taking it on the day he picked it up from the pharmacy, would you say that JC is adherent, non-adherent, or that you cannot tell? I'm going to need to see at least half the cards up to move on. All right. I see the mix is between A and C. In this case, it's actually C, and we'll talk about that in the next slide. So medication adherence has been defined as the extent to which patients take their medications as prescribed by their healthcare providers. And it includes things like taking it at the right time and the right frequency, and taking the right dosage. So we can see from that definition that JC wasn't necessarily adherent. We know he took the right amount over the period of time, but we don't know if he took it with the right frequency, or if he took it with food, if it was supposed to be prescribed that way. How many of you have seen or heard of patients that have a BID prescription that they take both tablets at the same time every day? That's an example of non-adherence, even though they're getting in the right dose or the right amount over time. Even splitting doses can be an example of non-adherence. Some patients split their doses to make them last longer. That's technically another variation of non-adherence. We're going to get into further detail on specific measures of medication adherence, but note here that often medication adherence is measured as the percentage of doses that patients take appropriately. That'll come in handy as we talk about different measures of medication adherence. We have to talk about compliance versus adherence when we're talking about this topic. Some have said that compliance, or using that term, suggests that the patient is passively following orders given by the doctor or by their other healthcare provider, and it's not based on an agreement with them. Based on that, some have said that using the term non-compliant is belittling to the patient, but I've also read other areas where it says there's no authoritative evidence saying that patients view non-adherent versus non-compliant as more derogatory. So really the key to remember is whatever term you decide to use for medication adherence, don't apply it directly to the patient. Don't call them non-adherent or non-persistent. We really have to recognize that it's not an easy process for the patients to adhere to their medications, especially with the number of medications that some patients have to take. So if we think about it, the steps to maintaining adherence or compliance: the patient has to keep a scheduled appointment with their provider. They have to accept the prescription that the prescriber writes for them. They have to fill it at a pharmacy. They have to pick it up and take it as prescribed. They have to follow up with the pharmacy to get their refills on time, and then they have to follow up with their provider for appropriate monitoring and new prescriptions. So it's really a lot of steps involved. How many people here have been late or skipped one of these steps before in the medication adherence process? Okay. I remember I had a pharmacy communications course where we had medication, I think it was M&Ms or some sort of candy that we had to take once a week, and then mark how many times we remembered to take it. And very few of us in the class actually did remember to take it on time. We've looked a lot into epidemiology of medication non-adherence. There's the potential that non-adherence could be defined as taking too much of the dose, doubling up, or other examples, but really most examples of non-adherence are errors of omission on the patient, basically missing or skipping doses. And electronic monitoring, such as pill caps that are electronic and keep track of every time the bottle's opened, have really given us a lot of insights on the epidemiology of medication non-adherence. One thing that was found was that a lot of patients will follow this white coat type adherence, and that's really where they decide to take their medication 3 to 5 days before they go and see the doctor, so that it makes it appear as if they've been adherent to their regimen. Also, the electronic monitoring of patients' adherence habits has revealed that patients fall into one of these 6 categories pretty evenly. So you'll see here that over half of patients take a drug holiday 3 to 4 times a year, or even more frequently, or worse, they don't take any of their doses. So it is quite the problem. The white coat adherence was an example of intentional non-adherence. We have both intentional and unintentional non-adherence forms. Intentional obviously being an active decision on the patient, whether that be to skip doses or to stop the medication without talking to their prescriber. There's also unintentional forms of non-adherence. This is a passive decision made by the patient, usually related to things like forgetfulness or carelessness or other factors that are out of the patient's control, such as poor health literacy. There was a U.S. survey of patients with chronic diseases that took place and found these results that in the past 6 months, 70% of patients reported some form of unintentional non-adherence, and then approximately 35% of patients reported intentional forms of non-adherence. So the question is, what kind of barriers do they have to maintaining adherence? Well, in another study that looked at those barriers, approximately 30% cited forgetfulness as a reason for non-adherence. And this is really an opportunity where we might be able to use some memory aids that we'll talk about later in the presentation. 16% of patients said that they had other priorities, and 11% said that they specifically decided to omit their dose. This is a chance where we need to talk with the patient and find out reasons why their medication adherence is a lower priority than other things. And then 9% cited a lack of information as a reason for non-adherence. So an opportunity for us to educate those patients and find out specifically what pieces of information they want. Another question here before we get into measures of adherence, talking about direct measures of medication adherence. That would include each of these except A, observing a patient administer his or her dose, measuring the drug levels in a patient's blood, or checking the patient's refill history. A, B, or C? I need some cards up. Oh, which of these is not an example of direct medication adherence measures? I see a lot of C's. That's good. That's actually correct. As you can see here, there's a ton of ways to measure medication adherence. Not one is really the gold standard. There's a lot of pros and cons to each of them, as we'll get into. It really depends on the healthcare setting, what measure is used, and also what intervention is trying to be evaluated for improvements in adherence. And then also the resources of the healthcare setting, and also confidentiality and ethical and legal considerations as well. The most obvious direct measure of adherence is directly observing the patient take the dose. Although in most settings this isn't really practical to actually watch the patient take every single one of their doses, and then additionally patients can actually hide their dose, making it appear as if they took it when they really didn't. Drug levels and biologic markers, drug levels such as getting levels on digoxin or their phenytoin levels, or biologic markers such as INR for patients on warfarin, or thyroid stimulating hormone for patients with thyroid disorders. These are potential measures. They're less time consuming than directly observing the patient, but they're costly. And another disadvantage is that they only give us a snapshot of how adherent the patient's been. So that weight code adherence might come into play here. And then additionally, metabolic variations in different patient populations can result in different results of these biologic markers or drug assays. So some patients might process drugs more quickly, and the levels may look lower than they are if the patient's being adherent. So because of these disadvantages with direct measures and some of the impracticalities of them, we're often more reliant on indirect measures of medication adherence. One of those indirect measures is self-reported adherence. It's simple, inexpensive, and really the most common used in the clinic setting. I know we used it a lot in the HIV clinic that I worked at. We would talk with patients and ask them questions about their adherence during their appointment. But a downfall of it is it relies on patient recall. So they have to recall since the last time they were there how many doses they missed approximately. And obviously the patient can be dishonest with you as well, which comes into play. I mean, how many of you have maybe lied to your dentist about flossing every day? I know I get that question every 6 months. Can't always say that I have done it every day. One of the ways that we can help with poor recall is having patients keep a diary that may that way when they come in for their appointment, we have a history of whether or not they took their doses. It can also benefit the patient in that they can go back and see how they've been doing, and they get some feedback from their own logs. Also, the disadvantage of self-reported adherence is it may create the Hawthorne effect. That's where the patient, when they know they're being monitored, specifically tries to improve their adherence. So it's not necessarily a bad thing if you can keep the patient feeling like they're being monitored and have a desire to be adherent, but it's not really doesn't really need to be our main motivation for patients keeping their medication, that they feel like they're being watched. We do need to use a careful approach when we're interviewing patients, though, during this kind of the screening for their adherence. We really want to be non-judgmental, so we want to use questions instead of saying, "Did you miss any doses?" Where the patient is more apt to try and please the person asking the questions and maybe not be so honest. Ask questions like, "How many doses did you miss?" Or in the last week, or in a given week, how many doses do you miss? That way they're expected to give a number. They know that you expect them to miss some doses here or there, and it really prevents them from being dishonest. We also want to talk about side effects with the patient about their medication. Ask them about what side effects they're having, what purpose they're taking the medication for, and what benefits they see to taking it. Usually when you ask them these questions, you can find out more about their adherence habits. If they can't list any benefits for taking it or why they're taking it, there's less likelihood of them taking it adherently. Another indirect method of medication adherence measuring is pill counts. It is objective, quantifiable, and relatively easy to perform. Although the problem is it's not really feasible in large patient populations. I know I don't want to count a patient's medication back and for every single patient just to find out how adherent they've been. And then also patients can, if they're intentionally trying to deceive the practitioner, they can count out from the bottle to leave just enough so it appears that they've been adherent. And the other thing is by just counting how many medication or how many doses are left based on their last refill, it doesn't measure the other measures of medication adherence. So even though they used up the right amount over a given time frame, we don't know if they took it the right way or took the right frequency of dosing. So the question might be, why don't we just measure the drug's effectiveness rather than counting how many medications or how many doses they have left? We actually can. We can measure a patient's disability pretty easily with a tool for multiple sclerosis. We can assess a patient's depression using a depression screening for patients taking antidepressants. But the problem with using these screening tools is that improvement isn't necessarily tied to adherence. Or even worse, if the prescriber is assuming that the patient is adherent and they see a decline in those scores or a worsening of their condition, they may decide to increase the dose or start a new prescription, and that's really unnecessary when they should be focusing on improving the patient's adherence. Fortunately for us, we have many methods outside of the clinic setting that we can use to monitor medication adherence. These are the electronic monitoring devices. They're precise, the results are easily quantifiable, and we can look at a patient's adherence over the duration of the time rather than just doing a pill count or asking them in the office when they come in. A lot of examples from anything from electronic pill boxes to alarms to actually bottles that come with caps that will track when the medication's opened. At Diplomat, we actually have something called the glow cap, which you see here. We use it for some of our oral oncology medications, and it's pretty interesting device. It comes with a cap that goes on your standard prescription bottle, and also this base station that plugs into the wall. And the base station and the vial cap communicate via Bluetooth, so they have to be somewhat close to each other. But every time the patient opens the cap, that's sent to the base station. And even more interesting, the base station is on a cellular network, which sends a signal, I think they use AT&T, to the patient's online profile, and it keeps track of when they're taking their doses. And if they don't, hence the name of the product, the cap glows, and I believe it makes a sound too. So a couple of different ways to try and keep the patient adherent. The advantage of it is that the patient can enroll caregivers into their profile, including their doctor and their pharmacy. In our setting, we actually get alerts when the patient has missed a dose, and somebody on our nurse adherence team will actually reach out to the patient and find out why, or at least try to remind them to take it. Another interesting one actually just came out earlier this month. The FDA approved an ingestible sensor. Has anybody here heard about that approval? Okay, this thing is about the size of a grain of sand, and it's activated by stomach acid. So it's meant for oral products, and when the product that's tied with the grain of sand is taken, the stomach acid activates that sensor, and it transmits a signal to a patch that the patient's wearing. Furthermore, the patch transmits a signal to the patient's smartphone app. So pretty interesting stuff. If it sounds more expensive than some of the other ways of measuring adherence, it's because it is. And additionally, these types of measures, such as the glow caps, don't, again, measure if the patient's taking it the right way. Just all it really assesses is quantity. And even if they do open up the cap, who's to say that they took their dose? So we need something a little less costly than some of these products. There are, for patients that are taking a beta blocker, for example, we can measure their heart rate pretty easily and pretty cost effectively. The problem is that these physiologic markers may be absent due to poor absorption of the drug or just plain ineffectiveness of the drug. So they may not be seeing the benefit you would expect from the dose. And then also we don't have a physiologic marker to be matched up with every drug for measuring adherence. So it's kind of limited what we can use these for. So far we've discussed many measures of adherence at the individual patient level. But what about healthcare plans that need to look at their patient population on the whole and see what their adherence levels are? Or in our case, we have to report levels of adherence for specific drugs to the drug manufacturer in some contracts. So we need to do medication adherence assessment on the entire population. Well, there's one thing that health plans and pharmacies have in their hands that they can use, and that's the prescription refill history or the claims history. Using these methods, it's really objective, relatively easy to perform and inexpensive, and it does avoid that Hawthorne effect because in most cases patients don't know that they're being monitored for adherence. There are some cautions to using these. One, you do have to have all the records available. So if a patient is not filling using their prescription benefits through their health plan, it may appear as if they're non-adherent. So if they're getting their free drug or paying just the cash price at one of the chain pharmacies, that's not going to show up on the healthcare plan's data necessarily, so that they will appear as if they're not refilling consistently. Also, this method isn't very well suited for acute treatments like antibiotic regimens, because we don't see a second fill occur to tell if they finished their first fill. Human error is also a potential problem with using prescription refill history. It's dependent on the technician or the pharmacist putting in the right day supply in the right quantity. If they don't put in the right day supply, they're not going to get the right calculation for adherence. And then lastly, the results out of here for calculating medication adherence can be overstated. So quite often patients refill a few days early. If they're consistently refilling early, their adherence level is going to be above 100% by using this method. The two most common methods for measuring prescription adherence using the prescription refill history are the medication possession ratio, or MPR, and also the proportion of days covered, or PDC. We're going to talk about those in the next few slides. The medication possession ratio, or MPR, is the most common. As you can see by the definition, or by the equation at the bottom, it's relatively simple. It's basically just a summation of the day supply that a patient got over a period of time divided by the length of that period of time. And then it can be either left as a decimal or converted to a percent. So you might see 0.9 or 90% reported for MPR values. As I said, this one has a fault. It can overestimate medication adherence, so patients that are getting early refills, they may look like they're much more adherent than they really are, or even worse, they could be stockpiling their medications. And then also another disadvantage of MPR is that the formula used by different healthcare entities varies. So some will cap the MPR at 1, so no single patient can be above an MPR of 1, whereas others will leave it uncapped. Where that comes into play is if they're doing an average MPR for their entire patient population, all those uncapped values will raise up the non-adherent patients, and it really looks better than it actually is. So the PDC, or the proportion of days covered, actually eliminates that inflation. You can see at the bottom it is a similar formula, but rather than a simple summation of the day supply, it looks at the days in a period that are covered. So we'll get into that a little bit more in some of the visual examples, but it is better suited for drug regimens. If you think about it, patients that are on a regimen for a disease state with multi-drugs, they really need to be on all those medications if the prescriber is using appropriate references. So HIV, for example, we come back to that a lot. Patients have to be on 3 medications in order for them to suppress their virus. And if they're not on all 3, a lot of negative outcomes can occur. So they shouldn't be deemed adherent if they're getting 2/3 of their medications consistently, but the 3rd medication they're not. So PDC actually takes that into account and looks at adherence for the entire regimen in addition to individual drugs. Recently, the PDC has actually become more preferred than the MPR, even though MPR is still most commonly used right now. The Pharmacy Quality Alliance has actually endorsed it as their preferred method of measuring adherence. And when I talked about CMS earlier on, how they have incorporated adherence measures into their plan ratings, they've actually used the PDC for that measure. So I only learned about PDC in about the last 6 or 8 months, and if you're like me, it's kind of confusing at first, so I think an illustration will help us in better understanding the differences between MPR and PDC. So we're going to look at a patient that has four drugs on their regimen and look at the differences between MPR and PDC. So we're looking at a 100-day time frame from day 0 to 100, and we're looking at the day supply, or the fills that they get at different periods of time. Each one of these I might refer to as an array. From day 0 to day 30, that 30-day supply is an array. So just so you know for future reference. So if we start to look at MPR for this drug, we're going to take a look at the days supplied. How many days supply did this patient get from day 0 to 100? And we do cut it off at 100. 100, yeah. So this is a simple one to start. This is what we'd call a adherent patient, and out of those 100 days, they had a 100-day supply, so their MPR is 1, or 100%. Fairly simple example. If we go on to PDC, we'll see that they also had 100 days covered, and so the days covered out of the period of time, 100 days, they also have a 100% adherence by PDC. Bear with me, drug 2 is also the same between MPR and PDC, but we'll start to see the differences with drug 3 and drug 4. So with drug 2, the patient had a gap between their fills between days 30 and 40. So in this case, they actually have a day supply of 90 for drug 2 out of the 100-day period, and 90 out of 100 we have a 90% adherence. Same for proportion of days covered. The patient had 90 days covered with that medication, therefore they have a PDC of 90%. So now we can look at drug 3. In this case, the patient actually refilled early on day 20. So when we're taking that into account for day supply, the patient actually got extra day supply during this 100-day period. So they had a 110-day supply of medication for drug 3 out of that 100-day window. So their medication possession ratio is 110%, which we know is not technically possible for a patient to be more than 100% adherent. So as I said, PTCE actually takes that into account and eliminates that inflation. So what it does with the arrays is it actually shifts the ones that are early to the right or forward in looking at what days are covered by the medication. So in this case, the patient has 100 days covered and their PTC is 1, which is more accurate than 110%. And then finally, looking at drug 4, we have a combination of late refill and early refill. If we were to add up the day supply within this window, we would get a 100-day supply, even though the patient was late on days 1 through 10 here. So again, this patient looks like they're 100% adherent by NPR standards, but they didn't have any medication from day 0 to 10. So PTC accounts for that. It does shift the early refills forward, and when you add it up, they have a 90 days that were covered, so that they have a 90% adherence rate. So you can see there's some differences in the two, and between NPR and PTC, if there is a difference, the PTC is always going to be less than NPR, although often it's the same. Now we've looked at individual drugs here in this example. It's also beneficial to look at the regimen. As I said, PTC is a better estimate of the patient's adherence to their regimen. So when we do the regimen adherence for NPR, it's real simple. We just do the average of all their drugs involved in that regimen. And because the patient was overly adherent on drug 3, that makes up for the fact that they were under adherent on drug 2. So it looks like they're 100% adherent to this entire regimen. PTC, when we're taking a look at the regimen, doesn't consider the individual drug PTCs at all. It actually looks at on what days were covered by all medications in the regimen. So for this patient, days 0 to 10, they were non-adherent. They didn't have all 4 drugs available to them. On days 3 to 4, they were non-adherent. So out of this 100-day time span, the patient was only 80% adherent to their regimen. Does anybody have any questions at this point about PTC versus NPR? It's a lot to take in the differences between these two measures, but they're becoming, yes?
It seems to me that it's a fairly good thing to have early refill as long as it's within the prescribed refill allowance, because someone then will run out of medication and they won't be non-compliant or non-adherent. There's some corrective factor to that.
Yeah, so the comment was that it's actually a good thing for patients to refill somewhat early rather than exactly on the day that they're due. And I totally agree, and I think PTC, the reason the PTC is becoming preferred is it actually does that in the measure, is it won't allow a patient to be above 1, but for those that refill a few days early, it's taken into account in the calculation. Did that address what your concern was? Yeah, okay. Anything else? So just to test the absorption of that idea, we have a question here. We're looking at the proportion of days covered for this HIV patient's regimen. So we need to look at all 3 of their drugs that they're taking, and we also have to look at what days they were covered by every drug in their regimen. Keep in mind that the arrays will move forward if they're early refills, but they don't move backwards when you're determining the days that are covered. So we have a choice between 100% adherence, 40%, and 60%. The best way that I know to do this is to just go down each column and look for gaps where they didn't have all 3 medications available. Are there any votes for 100% adherence? Didn't think so. Might be a little tougher to weed out between 40 and 60%. I do see a B in the back of the room. More Bs. Yes, it is actually 40% adherence. Even though it looks like this patient's fairly consistent in refilling their medications, there's a lot of gaps in their regimen where they're not getting all medications filled at the same time, or they don't have those days covered. So days, it's really only covered days 10 to 30 and days 50 to 70. So only 40% adherence by PDC standards. One final term we have to talk about when we're talking about adherence is persistence. They are not the same thing. Adherence can be looked at as a percentage of dosages taken correctly, as we talked about earlier, whereas persistence is really the duration of time from start of therapy to discontinuation of therapy. And that discontinuation of therapy is defined as when the patient exceeds a permissible gap. Now, different organizations, different people will define that gap as different amounts of time. Pretty common, though, would be for a patient filling 30-day supply of medications. If they go more than 45 days between fills, they would be considered non-persistent. So, like I said, notice here that adherence is reported as the percentage of dosages taken correctly, whereas persistence is a yes-no question. Either the patient is persistent or they are not. Once they exceed that gap, they become non-persistent. There's no real consensus on what an optimal level of adherence is. There's been a lot of studies done in a lot of disease states, and many will say that an 80% level of adherence is optimal for most disease states. But there is several other disease states where a higher level of adherence is necessary for achieving optimal outcomes. One of which, again, is HIV. There's been studies done with some of the HIV medications that if a patient doesn't take 95% of their doses, they're more likely to have negative outcomes. And if we're looking at assessing adherence on a population basis, there's 2 ways we can do this. The first one's fairly simple. It's where we take all the adherence levels for all the patients and we just take an average of those. Very easy to do. Unfortunately, you can have a lot of very poor adhering patients and a very good-looking average adherence, so there's some flaws to that. What a better way to do it would actually be to predefine some sort of optimal level of adherence for your population. So say you want 80% to be your optimal level of adherence. Then you would take a look at the percentage of patients that have that level or higher. And that's a better way to see which ones are at a goal than an average of the whole population. Even if we have an optimal level of adherence in mind, we do have to figure out how to get the patient there. This is the reason for a lot of research that's looked into patient factors that may predict or determine why patients are adherent. So far, there's not really been anything to say that sex, race, or socioeconomic status are predictors of adherence. However, there has been some research done in what they call the 3 C's. That would be the patient's commitment or their perceived need for the medication, their concern or perceived concerns, and cost or perceived affordability. We'll look more closely at these in the upcoming slides. So one study that was looking at these 3 C's as far as positive correlations between adherence and patient factors, we'll start out with commitment to the medication and cost of the medication, or perceived affordability. It had patients rank their, or they ranked patients based on their perceptions for these different characteristics. So patient that was in quartile 1 had no perceived need for the medication. They didn't perceive that they needed the medication. And you can see here that they were the most likely to be non-adherent. And it makes sense. If they didn't feel like they needed the medication at all, obviously they're going to be the most likely to be non-adherent. The same was true for perceived affordability. If the patient didn't think they could afford the medication, they were much more likely to be non-adherent. One interesting way of addressing the cost question with medication adherence is something called a value-based insurance design. And this is where the co-payments are actually based on the clinical value of the drug rather than the acquisition cost of the drug. And in this study, the plan, it was actually a Blue Cross Blue Shield plan in one of the southern states. They took generic medications for diabetes, hypertension, cholesterol, and congestive heart failure and waived the copayment for those medications. And then they also moved brand name drugs in those categories from Tier 3 to Tier 2. So you can see that over time there were significant improvements in adherence. At 1 year, for example, the ACE inhibitors, adherence was improved 2.5%, and at 5 years, nearly 5%. You'll notice here that there was little improvement for the ARBs and also for a category of drugs called CAIs, or the cholesterol absorption inhibitors. I believe that includes Zetia. The authors speculated that this is because there weren't any generics available in those classes of medications at the time of the study. So overall, we've seen that if a patient perceives that they can afford their medication, and they actually can afford their medication, they're much more likely to be adherent. But we need to consider some factors that negatively correlate with adherence. And the National Council of Patient Information and Education actually cited 6 factors in a report they released recently. Most, if not all of them, can be eliminated through relationship with the patient's healthcare team. Especially number 1 here, patient communication with their provider. Without the communication, no one really benefits. Patients can't have their concerns addressed. Providers can't find out about side effects the patient's having, preventing them from being adherent, and they can't find out about other special circumstances. Something as simple as the patient not having a mode of transportation to the pharmacy. To better understand the patient-provider relationship, a lot of research has been conducted. One study found that the most common reason patients did not adhere to therapy was that they were given the impression that the doctor didn't want them to continue the medication. So for cholesterol medications, 50% of patients in this study said that they didn't think they were supposed to be on it continuously. 63% for patients that were prescribed low-dose aspirin. I can't really blame the patients because I don't think a lot of prescribers say, here's your metoprolol, you're going to take this for the rest of your life. They don't really want to be downers in that aspect, but we really do need to communicate better with the patient on what the expectations are for the therapy. Another study looked at provider satisfaction with their jobs, and they found that providers that were more happy had more adherent patients. I think that this better job satisfaction correlates with better relationships with patients, so that patients see their provider as more approachable, patients can collaborate on their plan with their providers, and their concerns can be addressed. Some examples of concerns that patients might have include misperceptions about the seriousness of their illness, and disagreement with the doctor on diagnosis or the medication they selected. This is the 3rd C out of those 3 C's we talked about earlier, or this is the 3rd C, yes. It's really fairly intuitive, the results of the study that looked at the perceived concerns of a patient, so that those that had much higher perceived concern, they were least likely to be adherent. So if they don't have their concerns addressed, patients are less likely to be adherent to their regimen. One of those concerns might be the complexity of their treatment regimen. A lot of research has been done looking at the frequency of dosing for a lot of disease states. The general consensus is, and it makes sense, the more doses a patient has to take per day, the less likely they are to be adherent, or the less adherent they are. So for example, we're looking at this once daily dosing. There's a 15% greater adherence rate for patients that took once daily dosing compared to TID regimens. So this is pretty significant of a difference, and often it's really easy to address by actually looking at what other options are out there for the patient. If there's a once daily therapy and the doctor is using twice daily without any real difference, maybe we need to suggest to the prescriber that they change to something a little easier for the patient to take. It doesn't really matter if the twice daily medication is more effective if the patient is only taking half the doses. So before we get into some of the negative outcomes of adherence, I have another question here. Medication non-adherence can lead to which of the following negative outcomes? A, reduced quality of life for the patient, B, strained patient-provider relationship, or C, both A and B. Fairly easy one, yes. Both A and B are a couple of poor outcomes from non-adherence. Non-adherence can really be frustrating for both the patient and the provider. For one, it makes it difficult to determine the effectiveness of the medication if the patient's non-adherent. Also, it can result in unnecessary dose increases, inaccurate diagnoses, or even additional prescriptions being written. Also, non-adherence can result in adverse drug events, as we saw earlier on, such as withdrawal syndromes, overdoses, or exacerbation of the disease. Additionally, providers and plans lose out financially. As we said, they may fail to meet pay-for-performance measures and receive less compensation. And then there's a host of other negative outcomes that can come with non-adherence. I thought we'd actually take a look at some special patient populations to kind of get an idea of some of those negative outcomes from non-adherence. I think I've mentioned it twice already, HIV. This is really the ultimate example of adherence being important, although it is for really all disease states as well. But if you were in an HIV clinic, you probably heard the word adherent 20, 30 times a day. There's a lot of challenges for HIV patients. For one, they have to be on at least 3 different medications. So often that means they're taking multiple medications multiple times a day. The medications have terrible and long-term side effects, such as fat redistribution, nausea, diarrhea, even strange dreams. The medications are not forgiving. Unlike a cholesterol medication where a patient can miss a dose for a week, if they're off their HIV medications for a week, they could rule out an entire regimen of medications as being effective. And even worse, they could acquire an opportunistic infection that might be the cause of their death. So these medications are much less forgiving than some other classes of medications. HIV patients also have fewer healthcare options. I think I can count all of the HIV centers in Michigan on both hands. So unlike you and me, if we had a cough or had to deal with cholesterol or hypertension, we have a primary care provider close by, whereas these patients may have to drive hours away to see their HIV specialist. And HIV patients also have a lot of comorbidities. Diabetes is common, hyperlipidemia, and a lot of psychological conditions such as depression. And then finally, they also have to face stigmas for taking these medications. So to help address some of these challenges that HIV patients have, we need to provide education to them whenever possible and help them establish a support network, including their family and friends. Work with the patient to find a regimen that best suits them, fits their schedule, fits their tolerance, and fits their budget. Cardiovascular conditions are another example. They're a challenge for a couple of reasons, if not more, but in some cases, like hypertension, the patient doesn't actually feel the disease affecting them, so they have less of a motive to take the medication. And then additionally, for hypertension as an example, half of patients put on a single antihypertensive will not meet their goal. So they're going to be on multiple medications in most cases. And then for those that are not adhering to their medications, hospital admissions are more common. In the case of heart failure, patients that were non-adherent were 2.5 times more likely to be admitted to the hospital for heart failure, and they also die twice as fast as adherent patients. So what can we do for these patients? I think one thing we can do is really empower the patient. Give them a blood pressure monitor, or help them find a blood pressure monitor so they can track the impact of their medication on their own. If they can see the results of taking their medication or skipping doses, they're more likely to be adherent. Also, we can try more forgiving medications such as thiazide diuretics, or even something like a clonidine patch where forgetting doses isn't as much of an impact. And then more and more you've seen combination products are coming out for not just hypertension but hyperlipidemia, even diabetes. So in this case, if cost isn't an issue, let's try and get them on a combination product that will reduce their pill burden. I wanted to include pediatric patients as a specific case example, partly because I found some information on pill swallowing training. How many people have actually heard of a formal pill swallowing training as a way to improve adherence? Well, I knew it was difficult for not just patients but adults as well, or pediatrics, but adults as well, for a lot of these large capsules and tablets that they have to take. But it was actually proven in a small group of pediatric HIV patients that those that went through a pill swallowing training were more adherent. So that's one interesting thing I found in that area. If you think about it, usually the food that you chew up and swallow is much larger than the pill you have to take, so it makes sense that we just need to get them over the psychological barrier of a large tablet or capsule. Other challenges that pediatric patients face is they have a reliance on caregivers, obviously. They also have to cooperate in taking their medication, which can be more of an issue depending on the age of the child. And they also have lifestyle issues. Most pediatric patients are going to be in school, so depending on the disease state, they're going to have a supply of medications at school and a supply at home, or even worse, if they have divorced families, they're going to have one at mom's house, one at dad's house, one at school. It's very hard to keep all these medications in coordination so that they always have it available to them. And if these barriers result in non-adherence, their disease state is going to be uncontrolled, such as ADD or asthma. And then on a societal level, patients that don't complete their antibiotic regimens, that's going to lead to resistance. So some of the suggestions for improving adherence in the pediatric population is working with reward systems for them, making their medications more palatable. Flavor RX is a good example for making those liquid medications taste a little better. And then drug manufacturers actually make a ton of materials specifically directed at pediatric patients. So the materials are designed to show them how to take their medicine, why it's important that they take it. So reaching out to drug manufacturers to get some of these materials can really be beneficial to the pediatric patients. And then finally, the child also needs the support of their family and school system, obviously. Another interesting case to look at for adherence is osteoporosis. In most cases, these patients are going to be on a bisphosphonate or teriparatide, brand name Forteo, and then optimally they'll be on calcium and vitamin D as well. So we have the bisphosphonates with a lot of complex administration requirements, taking it with a full glass of water, remaining upright. We have calcium, which they're likely going to have to take twice a day, so you increase the frequency of the doses they have to take. And then if they have to be on Forteo, they're going to have to learn how to do a subcutaneous injection every single day for 2 years. So a lot of complexities with those medications that these patients may be on. The question is, what can happen if these patients are non-adherent? Well, it was found that women that were less than 80% adherent had a 16 to 20% greater fracture rate. And then those that were non-adherent had an increased risk of hospitalization due to fracture by 20 to 30%. So how can we help the osteoporosis patient population? As you know, there's a lot of frequency options available for the bisphosphonates, all the way from once daily once weekly, once monthly, even for Boniva IV, once every 3 months. So we need to work with the patient finding something that fits them both in terms of route and frequency. We also need to show them evidence. This may not be on our role as a pharmacist of showing them evidence, but it would be advisable to a prescriber to sit down with the patient and show them upon diagnosis their Z-score, showing that this number means that you have osteoporosis. And then also, as they go along with treatment, letting them take a look at their bone mineral density screening results so that they can see, is there an impact from my medication? That really, giving them that feedback really results in better adherence because they know that them taking the medication is resulting in a change. And then we also have to make sure that there's time to address misconceptions with the patient. And that really applies to all disease states. But I did read one anecdote about a patient that was just taking their bisphosphonate with a sip of water, and then they were complaining of indigestion and irritation. So it'd be an opportunity to talk to them about taking it with a full glass of water. For diabetes patients, poor outcomes can be very costly. We saw that slide earlier that for every $1 they invest in being adherent, they save $7 on the medical side. Another study looked at their overall medical spend. Patients with poor adherence with diabetes had an extra $4,000 a year in medical spend. So that's another way to look at the financial impact of non-adherence. And then also patients in another study that were less than 80% adherent, that was linked to increased blood pressure, A1C, and LDL levels as we would expect. And non-adherent diabetes patients are also more likely to require amputation, have a myocardial infarction, or have neuropathy. It's important in this population to involve the patient's family if possible. They're going to be critical to helping the patient manage their diet, exercise, and medication taking habits. And then as with other healthcare or other disease states, it's important that they establish a good patient-provider relationship, trying to simplify the medication regimen. Both of these can be beneficial to improving their adherence. And for the last special patient population, I want to look at geriatrics. This group is often on many medications and they have a number of barriers to adherence. As we talked about earlier, non-adherence can be related to 20% of their avoidable adverse drug events. A survey of geriatric patients looked at their perceptions of what they used to decide a medication was important or not important. Some of the things that they cited were pretty interesting. Patients said that a medication with a higher dose was more important than a medication with a lower dose. They also thought that a medication used to treat something, like a serious illness, was more important than something used to prevent a condition. And then they said that if the medication caused side effects when they discontinued it, that was more important than a medication that didn't cause side effects when they discontinued it. So the reason I bring these up is these are all misconceptions that we really have to work with the patient to expose and correct through good communication. So with all these variables we've talked about correlating with medication adherence and the negative outcomes, it would be really nice if we could predict a patient's adherence or likelihood of being adherent from the start of therapy. Then we could focus on those patients up front, being proactive, and we could leave alone the ones that already knew that they needed to be adherent. There's been a lot of screening tools developed, over 25 cited in one article I looked at. And these approach the predictive model from a lot of different standpoints. They pull in a lot of different factors. I think you're going to find some of these pretty interesting what they're using, especially the third one we'll get to. It's important that while we look at these, though, these prediction tools, that we recognize that the one-on-one consultation with the patient is really can't be avoided. It's really important so that we can understand patient misconceptions, provide solutions to barriers to adherence. So these tools can be used more as a way to facilitate that one-on-one consultation rather than replace it. One of the earliest prediction tools was called the Moriski scale. By show of hands, anybody here heard of the Moriski scale? Got a couple? Okay. Named after its founder, it was devised in 1986. It's a simple yes-no questionnaire completed by the patient, and then the healthcare provider will score it. And you can see at the bottom there, a higher score predicts lower adherence. There is a 4-item version of it and an 8-item, the 4-item obviously here. Really, it's been tested in a lot of disease states by a lot of authors or a lot of researchers, and the effectiveness of it has varied depending on the disease state. For example, in a study of patients on cardiovascular medications, while 3% of those patients scored a 3 to 4 or a low adherence level, 13% were non-adherent. So there's a bit of a disconnect between its predictive ability. A newer tool developed by Merck in 2009 is called the Adherence Estimator. This one you may have heard about through MPA. Has anybody heard of it, or better yet, been involved in the study, the pilot? Were you involved in it? Yes? Okay. Yeah, MPA actually sent out some requests for some of the pharmacies in Michigan to get involved in this pilot using this prediction tool. It's similar to the Moriski scale in that patients complete it themselves, but instead of asking about past habits, it asks about the 3 C's, their commitment, cost concerns, and yeah, I said them all. Cost, commitment, and concerns. But while you'll notice on the bottom here these results from one of the studies involving the adherence estimator, the score does correlate, so the lower risk ones are the ones that have higher adherence, but I do have some concerns. If you see on that PDC, the median PDC was 65% for patients that had a low risk of adherence. Most people would consider 65% really low adherence, so I would actually classify these patients as high risk for non-adherence. So there's some concerns with this. Here we have a look at the tool. It is fairly simple for the patients to complete, just three questions where they rate it. And then there's actually a tool where you can slide their answers in and do their scoring very quickly. And based on their overall score, they get put into one of those categories of risk for non-adherence. This one is not in your handout if you brought it with you. I forgot to add it when I submitted my slides, but it is probably the most interesting of the prediction tools. It's created by FICO, the Fair Isaac Corporation. It was developed in 2011. Anybody here familiar with FICO? Take out a loan, get your credit score. That's actually what they do, or one of the things they offer is credit scores. So FICO is actually getting involved in predicting medication adherence now. Their model utilizes third-party data, such as the patient's zip code, their consumer habits, their direct mail response rates, and a whole lot of other things that would leave your jaw hanging open. It's not really something that you're going to see in retail setting or hospital setting, at least not at first. FICO is targeting large healthcare plans and manufacturers for pulling in this data and doing predictive analysis. And also it's, I don't know the cost, but I know it's a lot more expensive than a piece of paper that you screen the patients with. You can see that they kind of break down patients' predicted adherence into deciles, and then they look at the patient's number of days they fill over a year period. So I think the idea is to have some sort of way to target patients that are non-adherent or likely to be non-adherent and hopefully improve their adherence. So with or without being able to predict a patient's adherence, we do have several options for tools that we can improve adherence depending on the reason for non-adherence. Some target forgetfulness or convenience. Other help the patient feel empowered and understand their own reasons for taking their medications. And others can help the patient get over affordability issues. Certainly technology has created many tools targeted directly at patients to help them take control of their medications. As you saw earlier, there are several applications available on smartphones and tablets. There's actually some evidence behind these type of applications. As far as text messaging reminders, in one study it showed that the PDC was improved 8% for patients that received text messaging reminders versus those who didn't. And then also there was an online prescription management account where the patient could keep track of their full medication regimen. And these patients saw nearly 20% improvement in adherence over non-users. Of course, there is a question of selection bias in the patients that use these tools. You might expect that the ones that are opting to use them are more likely to take control of their health anyways. But nonetheless, these tools are still useful and still being developed. In fact, earlier this month, late last month, Janssen, a drug manufacturer, released their Care for Today application. I downloaded it on my phone just to take a look at it. It allows patients to put in their full medication regimen, set up medication reminders so they pop up on the phone, manage their appointments with their healthcare providers, and it's free. So that's kind of been the trend with a lot of the drug manufacturers, creating free resources for patients. Also utilizing technology is this program created by the National Community Pharmacists Association. About this time last year they actually released it. It's called Simplify My Meds, and it's a prescription refill synchronization program. Basically it allows patients to pick up all their medications on the same day every month. How it works is it's an iPad application that the pharmacy staff uses, and it's basically a task list for them. So every patient that enrolls in the program, they will have certain tasks that the pharmacy staff has to complete using that iPad application. So about a week out, for example, the pharmacy staff will check for any prior authorizations that are needed for a medication. About 3 or 4 days out, they'll call the office to get any refills that they need for those medications that they're going to refill. The day before, they'll check their inventory, make sure it's adequate, and then the day of, they'll get a reminder to actually assemble the patient's order. So it's pretty interesting. Has anybody here used this in their pharmacy, this program? You do? What do you think of it?
Started it in June. Got 25 patients involved, ranging from individuals to a family of 6. It's a fairly complex algorithm to get things to coordinate, particularly with a family of 6.
Yeah.
But patients seem to really love it, and we're learning.
Yeah, one of the things I envision this being not just a benefit for convenience for patients, and hopefully having the potential to improve their adherence, but also one of the first users of it had an article in NCPA's journal, and they talked about how it freed up time for them to talk with patients. Does it do that for you as well?
They say, the program says we need to hit about 100 patients in the program before we see our workflow and ordering smooth out.
Okay.
But we're running a 27-day calendar, so, it's coming along. I think it's going to be great, but it's going to take some time. It's not something that you can just jump right into and have 100 patients your first month. Would not recommend it.
Thank you for the feedback. Moving on to another tool for improving adherence, motivational interviewing. In 2010, I had the opportunity to attend a weekend-long program down in Alabama at Auburn University, and it was a 20-hour CE, so I'm not expecting to make anybody here experts in one slide on the topic, but I do encourage you, if you're working directly with patients, to look into it. It's very interesting, and it's been shown to be effective in a lot of cases. The concept of motivational interviewing, or MI, completely goes against our urge when we're talking with non-adherent patients to say, you need to take this or else this will happen. The idea is that through a compassionate conversation with the patient, we're trying to help them expose on their own why they want to take the medication so that they state it. By them coming up with the idea in their own mind, the thought is that they're more likely to be adherent because they've created their own reasons rather than being told why they need to take it. And it's actually been shown to be effective, as I said. The lead for this training program actually authored a research trial. It was involving a medication for multiple sclerosis, Adherence. It's a once-weekly intramuscular injection that patients have to do. And discontinuation rates can be quite high with that medication, being that it's an IM medication. It can be kind of painful. So they enrolled patients into this program, and the treatment group received the motivational interviewing consultations, whereas the control group did not. And they saw that only 2 patients in the treatment group discontinued treatment at the end of the study, whereas 17 in the control group did. So it has some potential. We have a variety of physical memory aids we can offer patients to help them organize and remember their medications. There might be more available than what you think. There's one website out there called epill.com or epill reminders, and they offer everything from pill boxes to those bottle caps we talked about, keychains, watches, medication safes, locking zipper bags, and even just full devices that release the patient's full regimen on time. And it's all built in with electronic reminders. So there's a lot of things available depending on what the patient needs, if a reminder is something that would benefit their adherence. But as you would expect, some of these devices can get quite pricey. This one up here in the top right corner is, I believe, $800, and it does contain their full regimen and dispenses it on, or gives them a reminder on time. This one also isn't in your handout, but it doesn't have too much content you're going to miss out on as far as what's already written down on the slide. But for patients identifying cost as a concern, or they have a low perceived affordability, there's almost always an option to get the medication to them if they truly cannot afford it. Most of you have probably heard of needymeds.org. This a website does a great job of organizing research, organizing resources that help patients obtain funding assistance. They have manufacturer support programs, drug-specific copay cards, and even just broad prescription discount cards that they can use at their pharmacy. And if through the unlikely event that Needy Meds doesn't have their medication listed there, a lot of drug manufacturers actually have their own support program on their website where a patient can go in, select the medication that they're taking made by that manufacturer, and apply for support. Yes?
This is a real problem with Medicare D patients, and most of those programs don't work. Is that ever going to be addressed or not?
I haven't heard anything about it being addressed, but
it just sounds very unfair.
I know, I hate refusing those patients to use those.
They come in with these coupons and you can't do anything for them.
Mm-hmm. Yeah, it's frustrating. I have not heard anything.
Okay.
You've heard me talk about forgiving medications earlier with the HIV medications. There's been a little bit of research done specifically looking at the forgiveness of medications. I should have defined it earlier, but it's basically the number of doses the patient can skip before losing the medication's effectiveness. A lot depending on the half-life of the medication or how fast it's cleared from the body. It's not necessarily a tool for improving adherence, but it can be a consideration for patients that don't regularly take their medications, although it's probably a last resort. This one also is a new slide. For those of you working in community pharmacies, it may be beneficial to see your return on investment for starting an adherence program. The National Community Pharmacists Association has also developed this tool called an adherence calculator. It allows pharmacists to look at their gross profit after implementing a program. You can put in how many patients a day you plan to enroll and what their adherence is at baseline, and what you you expect to see over time. There are a few concerns with it, though. It does assume all patients move from a predefined level of non-adherence to 100% adherence. We know that doesn't happen. We might see some improvements, And then also it doesn't account for additional overhead and staffing. But nonetheless, it can give you an idea of the benefits you might see from implementing an adherence program in your pharmacy. I think there's 3 sections to it. You plug in your gross profit per prescription, number of different drugs prescribed for the average patient, number of days it takes the average patient to refill, and how many existing patients, like I said, that you plan to enroll into the program. And then it'll give you your estimated improvement in gross profit per patient, and then also overall over time. So with all these prediction tools and improvement tools that we've talked about so far, it's important to remember that, like for so many other things in healthcare, there's no single approach for all patients. You might find programs that work great for some patients but fail miserably in others. Some general recommendations I would include would be educating patients and family members, including those can help enhance the patient's support network and give them some sort of accountability as well to taking their medications. Help the patient take steps to make their medication regimen less complex, make recommendations for easier to administer medications, and offer reminder options that best fit their needs. And then make yourself more available to the patient and encourage them to ask questions, not being judgmental of their answers. So as you're seeing, medication non-adherence can lead to many negative outcomes. Very costly, close to $300 billion a year was the estimate. So by understanding measures of medication adherence, prediction tools, and tools for improving adherence, pharmacists can help patients achieve better outcomes.